prognosis following rotator cuff repair. And I have a little video, hopefully it'll play. And I'm risking 2 minutes of my presentation.
Move the hand. Thank you.
And there's no music, so I'll tell you when to
Sing it.
All right, cue right now. Wait a minute.
Right.
Welcome to the jungle.
Here.
Right here. Right here. Okay.
Welcome to the jungle. That was me imitating Axel. Oh. Oh.
And now cue hats off to the bull by Chanel. Thank you.
Oh, of course it shows a replay. Yeah.
Oh.
She wants us to really see.
It's actually Drew. That's Drew. Get the rope undone.
And finally, Garth Brooks' Rodeo is playing right now.
I know, right? Where's the trank gun when you need it?
We wouldn't act fast. And then it probably shoots him.
So yeah, this guy
Oh, gosh.
ripped his rotator cuff.
That's it?
And he had severe dislocation.
Oy.
Picture of him posting it after this.
So he sprained his ankle.
No. Keep us in business.
I guess it's not on there. There was a picture of him, but he had a severe dislocation and also torn rotator cuff muscle. All right, so my first article was a comparison between surgery and physiotherapy, or also known as physical therapy, in the treatment of small and medium-sized tears of rotator cuff. The purpose of this study was to present a controlled, randomized, I'm not sure if it's a clinical or controlled, or it is controlled, sorry, controlled randomized trial comparing surgical repair with physiotherapy in the treatment of small and medium-sized full-thickness tears of the rotator cuff. The hypothesis for this one was there would be no significant difference between the benefit between the operative and non-operative group. The method for this study was a randomized clinical trial. It's a controlled trial as well, clinical controlled trial. There's a minimum of 1 year follow-up. There's 103 patients included in this study. Patients had to meet the following criteria. The tears had to measure from, it could be less than 1 centimeter up to 3 centimeters. They had to have a lateral shoulder pain at rest or with exercise, painful arc. They had to have positive impingement sign, passive range of motion of at least 140 degrees of abduction and flexion. And they had to be diagnosed by MRI of a full thickness tear of at least 3 centimeters. And also a long axis ultrasound that would significantly or signify muscle atrophy around the deltoids. And the operation was a standard mini-open or open procedure by one of 3 experienced orthopedic surgeons. And then each patient received the interscalene block. It was a regional anesthesia. Post-op, the arm was immobilized in a sling. Passive range of motion exercises were initiated. And then after 6 weeks, they began active range of motion, and then the strengthening exercises were commenced after 12 weeks. And then for this study, they used the constant score for assessment. That was the primary assessment method of assessment. The baseline, you see the numbers there. The constant score is just you see it up there. It's the shoulder-specific outcome instrument. Some of you probably read about it. So they use that as the primary outcome measurement. And you see the measurements for baseline. And this is the American Shoulder and Elbow Surgeon assessment, the ASES. They did that They performed that. That was a secondary measurement they used. The conclusion of this analysis, the analysis of between group differences showed better results for the surgery group on the constant scale and on the American shoulder and elbow surgeon scale, and for pain-free adduction as well. My second article was the treatment of non-traumatic rotator cuff tears. The purpose of it was to compare the effectiveness of physical therapy. There's three groups: physical therapy, acromioplasty, and physical therapy. And the third group was rotator cuff repair, acromioplasty, and physical therapy. And they were all for the purpose to figure out which treatment of non-traumatic rotator cuff tear in patients above 55 years of age was the most beneficial, clinically speaking. The hypothesis was rotator cuff repair yields superior results compared to other treatment interventions. The study again was randomized, controlled trial, totaling 180 patients. To be included in the study, you had to be at least 55 years of age or more, atraumatic symptomatic supraspinatus tendon tears. So, and then they had to comprise less than 75% of the tendon insertion, which is documented by MRI. They had to have full shoulder range of motion and a written informed consent. And then you have the three groups there. The methods they used, physical therapy, they had each group had exercises, for their specific group. Of course, group one had targeted the glenohumeral joint motion and active scapular retraction for the first 6 weeks, followed by the 6 to 12 weeks progression dynamic from static to dynamic, and then exercises included, in-house along with written instructions to be given and performed at home. Group two was the acromioplasty and physical therapy group. The surgeons, there were 4 experienced surgeons. They performed the acromioplasty. They did a resection of the acromion if necessary, and that was figured out by an MRI if they needed to do that. Additionally, they did the biceps tenotomy, which is just releasing the biceps tendon here, and then the patient was also given written exercises to be performed at home after they did. They first improved the glenohumeral joint range of motion, and then written exercises to be given at home. And then the third is basically the same thing, repair. The third group was repaired, and then they gave exercises to be done at home as well. And then just coming right along here, the results for this study was they used the constant score as their primary method of assessment. And the conclusion of this study was the surgical repair of supraspinatus tear doesn't improve the constant score when compared with acromioplasty only or conservative treatment. So, and then lastly, my third article, prospective analysis of arthroscopic rotator cuff repair. The purpose was to identify probable predictors of function and tendon healing after arthroscopic rotator cuff repair that will enable orthopedic surgeons to determine which patients can expect a successful outcome. So the hypothesis was that there was a multitude of patient demographic, intraoperative, and functional outcome characteristics after the repair that significantly influenced clinical outcome. There were 193 patients in this study, and the inclusion criteria included positive imaging for rotator cuff tear and a failure of non-surgical treatment, so the conservative treatment didn't work. Patients who underwent treatment completed a preoperative questionnaire. They included demographic and social history. Rotator cuff pathology was described by lesion size, tear and tear thickness, and tendon involved. Additional procedures were also recorded, including acromioplasty, slap, tear, superior labrum, anterior posterior. They had to have that done. Biceps procedures. Limited targeted ultrasound of supraspinatus and infraspinatus tendons were performed at 1, 2, and 5 years post-op. And the results of this study was the increase in age and tear size were found to be significant factors in this study after the arthroscopic rotator cuff repair. And interestingly, in this study, with each year of the increase in age, it was demonstrated that the odds of tendon defect increased 108%, while the odds of a tendon defect increased 229% for every centimeter of increase in rotator cuff tear size. And for multiple tendon tears, the probability of tendon defect increased by 892%. Increased by 892% compared to single tendon tears. So in concluding, in this study, along with age and size of the rotator cuff tear, has the most significant association with tendon healing. Limitations, the first one was a follow-up period of only 1 year. Actually, both the first and second articles were limited by 1 year follow-up. And then the second one is also limited by the various interpretations of MRI images. There were 2 experts that couldn't agree on imaging. There were no post-operative MRI imaging recorded. And then on the third one, the limitations of that one was the number of patients lost at 1 year follow-up, 66%, and various surgeons performed the repair by similar but not identical techniques. And then rehab protocols were not standardized as well on that one. So, finally, in conclusion, summary, each of these studies identified a unique set of objectives, methods, and hypotheses specific to that particular study. Relating to rotator cuff tears, patients who received surgical repair scored better on the constant score compared to those who didn't. However, because each clinical trial has its own specific uncontrollable variables, more research needs to be done for conclusive evidence regarding superior methods of treating rotator cuff tears. And then rotator cuff tear size and age are also highly associated with rotator cuff tear prognosis. Sorry about that.
Limitation of time, if we're allowed one question for Drew. Does anybody have a question for Drew?
I can get the music if you need it.
Very good. Okay.